Good morning, everyone. We're going to go ahead and start today's monthly webinar series. Just a reminder, we have a 1 hour and it'll be available afterwards on our website. You get 1 hour of CME. Any resources that are mentioned today will be linked at the bottom or at the website for you to click on and see as well. We encourage questions throughout the webinar. If you would like them to be just private, send them only to Lindsay and she will make sure your question gets asked. Otherwise, you could just use the chat function and ask your question throughout the webinar. None of the speakers have any financial disclosures. The accreditation is through the Nebraska Medical Education Trust and designates 1 hour of AMA PRA Category 1. And physicians should claim only the credit that commensurate with the extent of their participation in this activity. The sponsorship is through continuing medical education through the joint sponsorship of Nebraska Medical Education Trust and LifeBridge Nebraska. And the Nebraska Medical Education Trust is accredited through the Nebraska Medical Association to provide continuing medical education for physicians. Today's speakers, I am thrilled to introduce Dr. Elizabeth Hartman. She is a board-certified neurologist and associate professor at UNMC Department of Neurological Sciences, where she serves as neurology clinical director. Dr. Hartman completed her medical degree at the University of Nebraska Medicine and completed her residency at the Cleveland Clinic Foundation and fellowship in multiple sclerosis at the University of Chicago. Dr. Susan Evans is a board-certified family medicine physician and assistant professor at UNMC Department of Family Medicine. Dr. Evans completed her medical degree at University of Nebraska Medicine and completed her residency at the University of Minnesota. Thank you both for being here. We have quite the topic to discuss today. So I think we'll turn it over to you guys and we'll let you drive the conversation.
All right, thank you so much. I will go ahead and try to share the correct screen. Does this look like you're seeing the right PowerPoint?
Yes.
Wonderful. Well, I'm very excited to be here and able to discuss nutrition in clinical practice with all of you today. It's been a large part of my practice for 20 years now. And I also teach medical students. About half of my job here at UNMC is teaching nutrition to medical students. And I find that as soon as they start to see the connection between nutrition and health, it's hard to unsee that. Beth, anything you want to?
Yeah, Dr. Schaefer, thank you for inviting us. Lindsay, thank you for organizing. As a neurologist, I also see the importance of nutrition too. I'm seeing people who are coming to me with the complications of malnutrition and undernourishment. And so it's really a pleasure to be able to share more about how we can approach this big topic and break it down, hopefully to be really meaningful for everybody in their practices. And also for us as individuals too, that us as physicians also need to take care of our own health. So I think it's great to learn all across the spectrum. And I feel like we should have one disclosure, and that's that Dr. Evans and I were medical school colleagues. So obviously it does not impact this talk in a negative way, but it's been a pleasure to work with her and collaborate on nutrition as well.
Thank you. All right, we worked together with Dr. Schaefer to come up with objectives for today. So our goals today will be to apply evidence-based nutrition principles in everyday clinical practice, provide practical patient-centered nutrition guidance across life stages and different clinical contexts, navigate common patient questions influenced by social media and nutrition trends, recognize the impact of social determinants of health on nutrition and dietary choices, specifically food insecurity, and identify when supplements may be appropriate and when food-based approaches should be prioritized. So this image comes from the Dietary Guidelines for Americans. And the way I use this image in teaching nutrition to medical students is just to show them that pretty much all of us have the information we need to counsel almost all of our patients on nutrition. The goal for healthy eating index is to get a score of 100. And as you can see, none of the age groups in the United States are reaching 100. And in fact, our teenagers have the least healthy diets, and our youngest and oldest members of our communities have the most healthy. But there's just a long way for all of us to go in eating healthier. So you don't have to be a specialist in nutrition in order to counsel a good majority of our patients. So our first objective, applying evidence-based nutrition principles in everyday clinical practice. So we'll be looking at a number of different diets today, including dietary guidelines for Americans, both the 2020 to 2025 version and also the 2025 version that was published this year, the DASH diet, Mediterranean diet, and the MIND diet. So dietary guidelines for Americans, published for 2020 to 2025, focuses on nutrient-dense foods, and this really overlaps with a lot of different types of healthy diets, most of which take out highly processed carbohydrates and added sugars, and then maybe focus on a specific type of healthy nutrients within those that are left after taking out those less healthy foods. These images are of my daughters because one day I realized that Mara on the left there probably hadn't eaten much of anything except carbs for about a week. And so we pulled out the MyPlate tool. I have some MyPlates I use for teaching and use those to put together a healthier diet based on what she wanted to cook that night. So the focus in the dietary guidelines are on vegetables of all types, fruits, especially whole fruits, frozen or fresh for both vegetables and fruits, grains, with a goal of at least half to be whole grains, which is an area where Americans really are not meeting the bar on whole grains. Dairy, at this point, the recommendation was fat-free or low-fat milk, yogurt, and cheese. That's shifted in the ones published this year, but in talking with some of the dietitians here who do research in the area of dairy products, it maybe doesn't matter if they're low fat or higher fat as far as the health of those. But I think still a lot of research could be done there. Healthy protein foods and the healthier oils, mono and polyunsaturated fats like olive oil. They also recommend foods to limit, including avoiding all added sugars in those younger than 2 years of age because they really don't have room in their diets to get all of the nutrients they need within their calorie limits if you're adding sugars to that. And they recommend less than 10% of calories per day starting at age 2. Saturated fat at that time was recommended to be less than 10% of calories per day, starting at age 2. And the sodium guidelines is less than 2,300 milligrams per day. For people in the United States, we're averaging more like 3,500 milligrams per day. So for everybody in the United States, this is one area we could look at. The dietary guidelines for Americans have not been as specific as some guidelines we'll see later from the Canadians. In 2020, the published recommendation was not one for safe amounts of alcohol, but for moderation. And they recommended 2 drinks or less per day for men and 1 drink or less per day for women. All right, shift over to Beth.
Yeah. And so this is a great thing to think about when you have those patients you're seeing in clinic who are like, I just don't want to take a medicine. So if they don't want to take medicines, we have alternatives and great alternatives. So especially with patients with hypertension that may be poorly controlled or patients who are mild and not ready to get on medicine, this is a great approach. And that's the DASH diet. The dietary approach is to stop hypertension. So if you're looking at about a 2,000 calorie a day diet, one of the biggest focuses here is really to drop that sodium level. For those of us who don't speak well in milligrams, and 2,300 milligrams is about 1 teaspoon of salt. And so people can still have sodium in their diet, just need to moderate that. And so as you can see, looking at that diet breakdown, really is a lot of similarities to what we're talking about with the general dietary guidelines, but really being more careful about the sodium content that people are getting. And by doing that, we actually see that we really do see improvements in blood pressure, even more so if we drop that sodium level to about half of a teaspoon. So it can really make a great difference in terms of people's overall health, reduce the long-term risk of things like stroke, heart attacks. So a great option for patients who are looking to really improve their diet. Building on that, I don't love the term diet because I think diet comes to sound as restrictive. And I think that we really want to focus on nutrition, and food is healthy if we're eating food that is not processed. So I like to talk about lifestyle because what we really want to do is implement changes that people can sustain over time. We know that diets that are fad diets may work in the short term, but if people can't maintain it, it doesn't work long term. So I love to talk about the Mediterranean lifestyle when people are asking about, is there a supplement, something else I can do, something else that can help me? Let's look at your lifestyle. And so I think this is a good graphic that kind of illustrates what we want to approach. That's a well-proven lifestyle. If you think of those like blue zones where we have people who are living long, healthy lives, active in their 90s, that Mediterranean lifestyle is often a part of those blue zones. And that base needs to be that healthy daily physical activity. So in Nebraska, most of us are walking around in some degree, but there may be a lot of driving involved. And so if we're not getting out and moving on a regular basis, we really want to encourage that movement for our patients, at least 150 minutes of the equivalent of moderate walking activity a day. So any movement counts. I encourage my patients that the movement that they enjoy doing is the movement to do, because if they enjoy doing it, they'll continue to do it. And then building on those healthy whole grains, fruits, vegetables, healthy oils like olive oil, healthy proteins, especially fish, seafood, poultry. And then you really fill up on all those things, and everything else is going to be a little bit at the top. And this is just illustrating to all those good nutrients that we're getting from that diet as well, that we don't need to supplement a lot of extra B vitamins because we're going to be getting all those things that we need. So this is one that I really focus on for people. And then moving to the next slide, we can blend both the Mediterranean and the DASH diet and end up with what's called the MIND diet. So what's unique about that MIND diet that's a little bit different from either of those apart is that we're still looking at that low sodium or salt content. But we're also throwing in lots of extra fresh berries or frozen, because we know that berries have a lot of good antioxidants as well. So lots of great options. And again, I think you want to make it approachable for patients. So any of these are proven to have good benefits. All of them are stepping away from processed foods and do have some good evidence of benefit for them.
So as I'm teaching students, I was happy to have found this more specific guidance on safe alcohol consumption, because we do know that alcohol consumption has so many health risks to it, specifically increased risks of a number of types of cancers and liver and kidney disease. But the guidance in the United States has been rather nonspecific, and it has gotten more nonspecific with the publication of the dietary guidelines this year. So it is considered safe to drink no alcohol, and it is very clear from the evidence now that there's no health benefit from alcohol. 1 to 2 standard drinks per week for men or women is considered to be safe. But even at 3 to 6 standard drinks per week, you have some increased risk of developing several different types of cancer, including breast and colon cancer. And I feel like we really deserve to know that as providers, and our patients deserve to know that as well. And then once you're hitting 7 or more standard drinks per week, you have also increased risk of heart disease or stroke. And so this website from Canada, I think, provides really good guidance on how to counsel our patients if they're really wanting to optimize their health as far as their alcohol consumption.
And
All
I would
right.
just add, in my clinic, I actually refer to alcohol as a neurotoxin because it is at high amounts. It is actually killing nerve cells, whether it's small fiber nerves that are causing painful neuropathy, whether it's increasing that risk of developing dementia. So just another way of kind of framing that is that unfortunately there is no safe amount of alcohol. There are safer amounts when we go to less, but there is no safe amount.
Thank you. All right, moving to our next objective, provide practical patient-centered nutrition guidance across different life stages. So for that, we'll again look at dietary guidelines for Americans and different clinical contexts. So just want you to be aware that there's a lot of good guidance, which you may be already aware of, from the American College of Cardiology. The National Kidney Foundation just has a wonderful website with a lot of nutrition information on it, broken down for like kidney stones or those with kidney disease not on dialysis and those for kidney disease on dialysis. So that's a really great resource. And of course, I recommend the American Diabetes Association to a lot of my patients because they have so much teaching and recipes and guidance there. And then the American Academy of Neurology has a lot of good articles as well, talking about neurological health and diet. So, looking at the dietary guidelines for Americans, as many of you might be aware, we had the new version published this year, and by law, by federal law, it needs to be published every year. Things were a little bit different this year. They moved from the MyPlate tool over to the inverted pyramid with a recommendation for eating more of the foods at the top. And some of those include meat and more meat and dairy products and whole fat dairy products. And so it's a little bit slight, some of those guidelines are a little bit different. But one of the biggest changes from my perspective as someone who teaches medical students about nutrition is they cut the size of the dietary guidelines from 149 pages down to 9 pages. Generally, in the past, there is always a large committee named to provide scientific guidelines to be interpreted into the dietary guidelines for Americans. That scientific information was not utilized this time, and the members of that committee were not included or named as a part of those who were writing the dietary guidelines this year. So to illustrate some of the information that used to be in the guidelines and is not there this year, um, in the 2020 guidelines, there were 15 pages that focus on birth to 2 years. And I use that information to help med students look at this as a resource for information for themselves and their patients because it's written at a quite accessible level. And so some of that information includes like this whole page on how do you know when babies are ready to start solid foods? And these images down below of what is a more processed food that you could stop giving to your kids and switch to a less processed food. And then also a lot of information on different types of vitamins we need to think about in newborns and those up to age 2. In the 2025 version, there's just one page focusing on birth all the way up to 4 years of age, and that's what I have in this image here. So there's not as much information for physicians or families that we're taking care of in the new version. And then also in the 2020 version, there's a whole chapter on pregnancy and lactation nutrition and a chapter on older adult nutrition, whereas in this year's version, this is the one page that focuses on pregnant women, lactating women, and older adults. So in my teaching, I'm continuing to utilize the guidelines from 2020. And if you're looking for more information, you can download those for free off the internet still as well. They are continuing, all the older versions are still available. All right, and Beth?
Yeah. And so I think this is a good time to reframe, when people are asking about what supplement can I take, the truth is that there's not really a lot of evidence behind a lot of what people are hearing. They're seeing a commercial, they're seeing something on social media, they're hearing from a friend. And so we want to bring them back to what actually has evidence base. And there is lots of good evidence there about nutrition and what we can do that's actually beneficial from nutrition. This is just one example that came out not long ago about the neuroprotective effects of the mind and Mediterranean diets. They took about 1,500 people. Half of them were normal controls, half of them had Alzheimer's disease, and they looked at the effects of the Mediterranean diet. And going forward, in terms of their findings, what they really found is there was a really big difference in terms of what we saw in terms of the risk of both cognitive decline, developing mild cognitive impairment, and diagnosis of Alzheimer's disease. So really did see that had true impacts in terms of nutrition. And this is a big breakthrough that we're seeing in terms of this research. It's been hard to kind of separate out the different parts of what may contribute to people's outcomes. And so it's really exciting that we're finally getting some good data that can really support these diets. That, to tease out whether the diet by itself is making a difference takes a lot of time. So we really do have good evidence to say this is where we should put our energy, this is where we should put our focus, and shouldn't distract and try to focus on a supplement that may or may not have any benefits. Yeah, and so they were really showing that not only the risk of really phenotypes that can be negative in terms of cognitive decline, but also saw lower levels of things like amyloid beta, tau, neurofilament light chain markers that are indicating neuronal damage. And so really did see that those berries, leafy greens, whole grains, all those micronutrients are really making a big difference in combination, that you really just can't supplement anything to replace that combination that comes from this approach and lifestyle. Similarly, I feel like you can't talk about nutrition without thinking about the other part, which is movement or exercise. And again, for some people, exercise is a negative connotation. So movement counts, but really, again, seeing that any degree of movement can have benefits for our body, for our brain, for our heart, and we have studies to prove it as well. So looking at this as well, we can go forward to the next slide, Dr. Evans. So really seeing that we're seeing improved blood flow to the brain, reduce inflammation, and enhance neuroplasticity. Other studies that I really enjoy to see have showed that we see increases in BDNF, brain-derived neurotrophic factor. So that's one of those factors that really tells neurons that they need to survive and they need to connect and have synaptic plasticity. So really seeing that we can do activity that can really modulate and improve our brain, improve our brain performance. All of us know people who have had dementia, and nobody wants that. And so I think this can be a very good motivating factor that movement, focusing on improving our diet, improving our lifestyle, really can have great benefits for us, reduce the risk of dementia in the long run.
Great, thank you. Moving on to navigating common patient questions influenced by social media and nutrition trends. So the first thing I talk about as far as navigating a fad diet in clinic is just starting by asking the patient what they are eating. Because I find that their understanding of what a diet may be could be very different than your understanding. So just before the pandemic, the keto diet was very, very popular. And so I would ask patients, though, what are you actually eating? I'd say, so are you doing like keto, like putting butter on your bacon? Or are you doing keto, like you're still eating some vegetables and maybe some fruits along with it? And I had one of my patients with diabetes. She's like, oh, I'm a vegetarian. I'm eating veggie keto. I was like, well, I am not going to worry about you. One, she's not going to be getting 60 to 80% of her calories from fat because I don't think you can even accomplish that with a vegetarian diet. But I know that she's not going to be focusing just on like meats and processed meats and no vegetables then. And I also know I don't have to worry as much that it won't be sustainable because she's obviously eating a more well-rounded diet. Not the keto diet, but that's fine. And the other thing I find is most fad diets do cut out unhealthy, unprocessed carbohydrates and added sugars. Like if you look across the board, and then within them, they're often, focusing on specific types of nutrients that that particular diet wants to focus on. And often they're pretty much fine. The last really, really unhealthy diet I remember was probably about, I don't know, it was soon after I got into practice. So about 15 years ago. And that was the HCG diet, where people were injecting themselves with a pregnancy hormone and then only eating 600 calories. So that was basically a starvation diet, and like hair would fall out. It wasn't the least bit sustainable, but just finding out what they're eating and then maybe working within that what they want to eat, to make sure it's healthy and safe enough. Intermittent fasting does seem to be more sustainable than many other decreased calorie eating patterns. Again, I ask folks, so when you say intermittent fasting, what are you actually doing? And I had one patient, she's like, well, I don't eat after 7 p.m. And I was like, that sounds great. I did have, we did a case study once for a nutrition class I teach on one of my patients who was diabetic and was doing intermittent fasting, but doing a 24-hour fast, and looked into it. That even he did fine with it and seemed to be fairly safe. So just really, as with really talking with patients anytime about what they're eating, the most important, way more important than telling them what to eat, is asking them what they are eating so you can meet them where they're at. Oh, and then this year, the question is, how much protein should we be eating? And so coming again to the new version of the dietary guidelines for Americans, I really appreciated that the American College of Cardiology came out with a statement almost immediately that was really helpful. On the left here, you have all the things in this year's dietary guidelines for recommendations that are evidence-based. And then, as the college put it, other 2025 dietary guidelines recommendations, and that maybe aren't evidence-based. And they point out that it recommends raising the recommended daily allowance for protein from 0.8 grams per kilogram body weight per day to 1.2 to 1.6 grams per kilogram body weight per day. Not necessarily evidence-based, but their guideline, if you're, wanting to stick to these, their recommendation is just counsel your patients on trying to get that added amount of protein from plant sources of protein that are known to be very healthy and very safe. Another guideline that is new this year is including butter and beef tallow as a part of the healthy fats. In fact, in some of their when they're going out and meeting people across the country, they've been bringing along food trucks where they're cooking French fries in beef tallow and that kind of thing. Well, as the cardiologists point out, data from studies show that saturated fats such as butter really raise LDL cholesterol compared to olive oil, and so they're not recommending making that change for our patients at this time. All right, our next objective then is moving on to recognizing the impact of social determinants of health on nutrition and dietary choices. And so this image looks at the way so many factors go into our health outcomes that really we don't have a lot of control over, except at a societal level, as far as how well do we support people that may be living in poverty or have a disability? How well do we support their food needs? How well do we educate people starting at an early age? How well do we look at maybe extra supports that people will need depending on some of these social determinants of health in order to have a healthy diet and to manage their food needs and have then healthier outcomes? So one of my main area of doing some small studies with our patient population here, working with students doing studies, is looking at food insecurity within our patient population. And what I've really realized is as we're moving into teaching a lot more nutrition in medical schools, which the Department of Health and Human Services is really encouraging at this point, I'm really hoping that as we teach students how to talk with patients about what foods they're eating, is that we definitely teach them that the first step is screening for food insecurity. And the teaching that calories are primary. Yes, we want our patients to be eating healthy foods, but if they don't have enough calories, that is what they're going to focus on for their families first and for themselves. And it really is primary. We need to, as a community, be sure that our patients and everyone in our community have enough food. And then from there, we can really focus on healthier foods. So, the US has a level of food insecurity around 13, 14%. Families with children, that's even higher at 18%. And I am afraid that we're going to be looking at a decade where food insecurity is going to get worse and worse. The One Big Beautiful Bill from July of 2025 cut SNAP benefits by 186 billion over the next 10 years. Not only that, they're changing it. This used to be a federally funded and state administered program, but they're going to shift it to more state cost sharing. So it'll depend on our state governments whether they're going to choose to make up some of that difference for the people in our state or not. They're also expanding work requirements to people with anyone who doesn't have a child under 13 years of age, and also including people that are unhoused will have work requirements in order to get these benefits, and expanding to some more veterans having work requirements. And it's restricted to lawful permanent residents, and it ends inflation-based increases in healthy food costs. So it had been for a few years since the pandemic tied to inflation, the amount that people would get, and more closely tied to how much it costs to eat a healthy diet. Then just this spring, the administration's budget proposal aims to cut cash value benefit for fruits and vegetables to the Women, Infants, Children, or WIC program as well, cutting it for breastfeeding moms from $52 to $13 per month and children from $26 to $10 per month. And as you know, there's not a lot of fresh fruits and vegetables you can buy with $10 per month. So checking with our patients about food insecurity is going to be really important. Some of the programs we do have, WIC is for age birth to 5 years of age. So if you have children in your practice, or moms with children, and sometimes dads or grandparents with children, just check, especially with those age 3 to 5. They're not necessarily signing up for those benefits as much as families with newborns up to age 2. And then why does it cut off at age 5? Well, the ideal is that the National School Lunch Program is going to step in from there and provide healthy meals for children in school. Free lunches in schools, universal free lunches are in these, I think it's about 8 or 9 states now. Nebraska does not have that yet, but we did pass a law, LB 966 this year, that for the next 5 years, any children, families that qualify for reduced price lunches actually will get them for free. So that's a good benefit for the next few years. All right, our next objective, identifying when supplements may be appropriate and when food-based approaches should be prioritized instead.
Yeah. So we want to focus here, and not everybody comes in looking the same. So we all know that behind door number one, maybe one patient, and then behind number two, completely different patient. So we need to think about who are patients who are at higher risk of nutritional deficiencies and who needs to have maybe a different approach that even if they're eating as good diet as they can, may still be struggling. So just that reminder that there's lots of patients out there who may have malabsorptive states from anywhere across that GI system, whether they have celiac disease, where if inflammatory bowel disease, pancreatic disease, cholestasis, H. pylori infection, pernicious anemia. Our bypass patients also, certain medicines, especially cholestyramine and metformin, can impair absorption, especially of some of our B vitamins, especially B12, chronic PPI use, antacids, and those who are using too much alcohol. All of these things are risk factors for those nutritional deficiencies. And so when we're seeing those individuals, they may benefit from additional supplementation rather than just focusing on diet. Additionally, pregnancy, lactation are also states where individuals need more nutrition to feed not only themselves and stay healthy, but also their developing infant. Those who are doing strict vegetarian and vegan diets can do it really well, but many of them do need to supplement some of those B vitamins that really are only coming from animal products. Our patients who are hyperthyroid also have higher nutritional needs. Critical illness, so especially in those who are in the ICU, have prolonged infections, need better nutritional support to support their recovery. Our elderly can be at higher risk of developing that age-related hypochlorhydria that impairs absorption as well. Nitrous oxide isn't used very often anymore, but sometimes in dental procedures that can potentiate development of B12 deficiencies, can also be misused or overused, such as huffing. It can cause problems as well. And then don't forget that people who have poor dentition also have to adjust their diet as well. So multiple risk factors that can impair patients' ability to get good nutrition and may benefit from additional supplementation. And so when you're seeing someone in clinic and says they're really tired, fatigued, have brain fog, these days it's easy to say, oh, it's COVID brain, that you have post-COVID brain and it'll get better. But I want to encourage everybody to pause and say, let's look and see if there's something else going on. So while yes, post-COVID brain can make people feel really tired, sometimes it could also unmask something else that had been going on. So remember that especially for cognitive or psychiatric symptoms, think about checking some of those B vitamins, especially B12, B9, B1. Those can be really important. I'm seeing a lot of ferritin being very low as well in these individuals who are very fatigued, especially in women. Up to 1 out of 3 women can be low in iron, so worthwhile checking that as well. If they're having sensory complaints, same thing. Want to look into looking those B vitamins in more detail. So really want to drill down and really follow the symptoms and look into them in more detail. If you're like, I don't know which to check because everything that review system says positive, the highest yield vitamins that you can check is going to be those B vitamins, B1 or thiamine, B12, which is cobalamin, B6, which is pyridoxine, B9, which is folate. So it's going to be your highest yield. But in patients who may have, for example, gastric bypass, copper is good to check as well if they're having sensory changes. So good to look at these, especially in those high-risk patients, to find those deficiencies and identify them early before they cause long-term complications. Just drilling down a little bit more on that iron deficiency. If we're only waiting for anemia, we're waiting too long. That iron deficiency can cause symptoms much earlier. And some of those can be things like insomnia, just fatigue, tiredness, irritability. And so we really want to look for it. And iron by itself is not the only accurate measure. We really want to check that ferritin as well. Goal ferritin level for patients who are iron deficient is going to be closer to 100. And I'm sure all of us have seen these patients who have had very low ferritins in clinic. So of course we want to look and evaluate and see why are they iron deficient first, whether it's truly they're not getting enough iron in their diet, whether there is a GI source of loss, whether they're having heavy periods that need to be addressed. And then we really want to supplement those individuals and follow them and make sure that we get those levels normalized and keep them normalized. In practice, what supplements should we think about using in these patients who are higher risk, who may not be able to get enough from their food that they're eating? Folate for all women of childbearing potential, we should be doing because that risk of neural tube defects. So at least 400 micrograms daily, and that's going to be in a regular multivitamin for women or in those prenatal vitamins. Because of where we live and our distance from the equator, most of us are going to get vitamin D deficient here in Nebraska during the wintertime months. Some of us even during the summertime months who may not be getting sunshine to get that exposure to create vitamin D. And so vitamin D supplementation is something I think that all of us can benefit from during the wintertime months. 2,000 units of vitamin D3 is a safe amount. Some patients are doing high amounts if they're doing more than 5,000 units a day. Over time, they can develop some toxicity. It takes a long time to develop. Vitamin D gets into our fat stores, and so it can take some time to develop. But if they're taking more than 5,000 units a day for long periods of time, think about checking a level every year or so to make sure they're not getting too high and at risk for developing calcemic complications like kidney stones. And then vitamin B12, especially those restrictive diets, those meds like chronic PPI use or metformin, vegetarian diets, think about supplementing that. About 500 micrograms a day is going to be plenty to keep them from getting low on that. For patients who may have troubles with constipation, leg cramps, even there's some data for migraine, magnesium can be a supplement that can be helpful for them and has some evidence of benefit for many individuals. Unless, of course, they have chronic kidney disease, then we definitely want to avoid it. So we don't want to get them too high on it. We talked about iron in a little bit more detail. So typically you want to supplement 325 milligrams every other day with vitamin C to help with that absorption. And again, that ferritin goal, we want to get it well over 75, especially if they have restless leg syndrome. That can actually improve it, even if their iron level is normal. And then many individuals now have gone through bariatric procedures, whether it's a sleeve, a gastrectomy, or a Roux-en-Y bypass. And so we want to stress to individuals that that supplement is not just for the short term, it is for the long term. So they really need to stay in that bariatric multivitamin for the rest of their life because their absorption has been changed for the long term. So really want to stress that and so they can stay on it and not develop complications of nutritional deficiencies. And just that reminder, so patients are going to say, gosh, I heard about this. Can I try this? And again, can they try it? Yes, they could many times. But should they try it? Maybe not, because if they're using that energy, that time to take a supplement with unproven benefits, but not getting that movement, not getting that focus on nutrition, they really may be doing some harm for themselves in the long run. So in general, it's not worth that investment for our patients. It's better to invest in the things that are proven, that there is no one supplement that can improve brain health, despite what people are seeing on commercials. And then this is a big trend as well. Our GLP-1s have really changed how our culture is approaching things. Oprah has done a big special focusing on GLP-1s and how it has changed her life. She'd been a long-term spokesperson for, weight loss companies. And so many patients are trying them, whether they are overweight or whether they are normal weight. And so we do want to just look at these patients and remind them that we need to focus on nutrition. So people may want to pursue them for appearance and look, but if that's their goal, we still want to make sure that they're doing it in a healthy approach. And so whether people are using GLP-1s or whether they've been through a bariatric procedure, In general, they're not going to be able to eat as much often because they don't have as much stomach capacity and or their appetite has been reduced. So we really want to make sure we're reminding patients to focus on nutrient-dense foods. So the food that they do eat, we want to get that nutrition that they need and hydration. The dehydration can be a big issue for these individuals as well. To make sure they're getting enough protein to maintain their muscle mass and physical activity to do it, and at least a daily multivitamin for those individuals to make sure they may not be missing some things that are really important. A reminder for people who've gone through bariatric procedures that the guidelines are to check nutritional labs at 6 weeks, 3 months, 6 months, and then annually. So if you've seen a patient who underwent a bariatric procedure many years ago and is no longer following their bariatric team, that's a good opportunity to really look at their nutritional status to see, are they low on some things. And then I think this is just a good graphic that do people want to consume a lot of supplements or they like to eat this beautiful, healthy plate of food? So that's really the goal is to help people and guide them.
Thank you.
That was wonderful. Thank you so much. Lindsay, from the questions that were submitted, did we cover them?
Yes, you guys covered most everything that came in through registration. There was a couple other questions, and I'll start with the person who's on right now. There's a couple in the chat. How do you cancel a patient with a very restricted diet, for example, an adult with a white diet, mostly by choice, who refuses to even try other foods?
Um, Again, I just kind of ask them what they're eating and then maybe go through it with them. And as a family doctor, I might say, hey, how about, we see you back in a month and check your weight and maybe check some vitamins, or maybe go ahead and check some vitamins today and see how they are. But, I've been doing this long enough to know that people are going to do what people are going to do. And so keeping the conversation open, I think, is a big part of motivational interviewing, and not having folks, not telling them what they're doing is wrong or bad necessarily, but maybe helping them kind of talk through it themselves of what are, some of their goals and that. But yeah, asking them what they like about it and learning a little bit more.
Yeah, and I feel fortunate that we do have a nutritionist that's affiliated with our clinic. So I do a lot of referrals to the nutritionist to try to help them kind of really look in more detail. That I think that's a great resource if you have it available. The second question about local restaurants here in Omaha, there's at least two Mediterranean restaurants. I think there's more than that, though. I know Cleo's, which is a more kind of upscale, fancy one downtown, is very Mediterranean friendly, and that's the whole theme. Medis is closer to, it's not fast food, but it's a little bit quicker, and that's out at Village Point. So there are at least two, but I think there's more than that that are Mediterranean restaurants here in Omaha.
I would say El Basha also
Yeah.
on Pacific. Yeah.
Hmm.
Hyper local produce would be farmers markets, and then the new farm to store market in Dundee, which is right there on Underwood, are the ones that I think of first. There's probably others also.
Or growing our own produce. So a lot of us are doing that more in our homes too. So anybody can grow herbs in a window. So yeah, great resources.
How do you
You
guide?
talked a little bit.
Oh,
Oh,
go
sorry.
ahead. I
No,
was
go
going to
ahead,
say,
Dr. Schaefer.
how do you guide with advice around organic? Do you talk about the Dirty Dozen? Do you talk about, just to get some relief on pesticides? I know that's a little off topic here, but it does come up, with berries and trying to eat more berries. How do you guide your patients on that?
Um,
Um,
oh,
Go
go
ahead.
ahead, Beth.
Yeah, I would say that we wash things off ideally, and that's going to get rid of a lot of that residue. And so I think that still the benefits of fresh fruit, vegetables is going to outweigh any potential negatives. And so I encourage people to eat fruits and vegetables, regardless of whether it's organic or not. That I think that if we start from the place of getting more fruits and vegetables, we're still having more health benefits than not.
And yeah, and if they can afford it, that may be worth it.
Mhm.
Um, but otherwise, just getting those fresh or frozen fruits and vegetables that fit within their budget and their lifestyle.
Mhm.
We did have one, and Dr. Hartman, you talked about, you have the nutritionist in your office, but someone said, how do you decide when to counsel patients yourself versus referring to a dietitian?
Mhm. What I do in my practice is that I have a lot of kind of pre-made guidance because these questions come up so much. So I have a smart phrase that I have about brain health that talks about all the modifiable risk factors for cognitive decline and dementia. So I share that with all of my patients. I feel like a lot of what we talk about in clinic can't be absorbed in the clinic visit. So I go through the highlights with them in person, but also try to give them resources to go home and read through and digest and give them more to read through. So every patient that asks about, I'm going to give them some of those kind of highlights that if it's something I talk about a lot, I create it as a smart phrase and put it on their checkout sheet so they have that information. But if it's someone who is more complex, that they do have some food intolerances, they've tried different things and are just still struggling, they're having GI issues, then that's a person that I may not either have the expertise to, I don't have the time to do it. And so that's when I'm going to offer them to see if they can meet with a nutritionist. Sometimes it's a patient who really just doesn't know how to approach their diet. They haven't learned about the basics of carbohydrates and protein, and they really just need some of that basic education to build from. So that's a patient that's going to benefit from it a little bit more.
So sometimes we have really good access to dietitians. Currently, we're probably scheduling about 2 months out. For a little while there, we couldn't send anyone with obesity or diabetes. We only had enough dietitians for those who were underweight. But underweight is definitely that area where I want to figure out underweight and weight loss. I want to figure out what's going on. Is there something, that's happening as far as what they're eating or not eating? Or while I'm looking into what could be other causes. And then celiac, especially new diagnosis of celiac, or even coming back to it again, somebody isn't feeling good or maybe isn't doing that. That's a tricky one. I don't. I have some patients that are willing to try a low FODMAP diet for irritable bowel symptoms. In that case, I think that's one that really seeing a dietitian is very important. I think our role too is I'm happy to send anybody who's interested in seeing a dietitian. But I think our role is to have talk with our dietitians, kind of know what they can expect when they go there, and then we'll be the ones following up on it again. They're not going to see the dietitian forever. They'll see him for a few visits, and then we'll say, "What did you talk with about? What are you guys working on?" Following up on that over time with them as well. I really see them in our clinic. They're a part of our patient-centered medical home, and I really like to have it in that way. But the truth is, it's another visit, it's another copay. It may take a little while to get in, and so there is a lot of loss to actual referral in getting to a dietitian. So doing the basics in our clinic is always worth that, and then hopefully teaming up with a dietitian will also.
You talked a lot about food insecurity, and I know a lot of our physicians have made comments about, tackling social determinants of health for their patients is extremely difficult, especially now. So if you would find someone that is food insecure, what resources would you generally give them or refer to them for food insecurity?
The way I do my screening is within Epic now, and for probably anybody, for any of our annual exams, our rooming staff will screen using the Hunger Vital Sign, which is basically within the last 12 months, have you worried that you'd run out of food, or have you run out of food before you had money to buy more? And I've then asked some follow-up questions. Are you primarily utilizing grocery stores or also utilizing food pantries? And if so, which ones have worked well for you? And that's a lot of the way I have learned about which food pantries my patients are primarily using and have sort of those resources to recommend in the area. So in Omaha, kind of Midtown, Eastern Omaha, I know that Together has a food pantry where you get to go around and pick which foods you want, and they have some produce and some meats, along with the Heart Ministry Center at 24th and Binney. And not all food pantries have that as an option. And then otherwise, it's usually the church that's closest to them, that's maybe walking distance, that has a food pantry. And those can really vary as to how often they're open. If you're in a rural area, when our students are on their M3 family medicine clerkship, I do a lecture with them and I have them look up what food resources are available in that community and how often are they open and what are the requirements. You want to know, are they going to require some sort of ID? Are they going to require a social security number? You're going to not send as many patients there because that could be limiting. And that's a question that's not ours to ask and certainly not to document. So I would never ask that in clinics. So I want to find places that those are not necessarily needed. So those would be local. And then you want to know about the federal programs and just be sure, can your community health workers or your social workers help people get signed up for SNAP benefits or WIC benefits? Does your patient maybe qualify for Medicaid waiver? Are they disabled in two areas and they're on Medicaid? They may qualify for in-home care. They may qualify for like up to 21 meals delivered per week through that Medicaid waiver. So, and then also my patients are utilizing Meals on Wheels. Some love it, some hate it. You just never know. Having options is so important. And day programs. The Intercultural Senior Center is a lovely option for patients here in Omaha as well. They have transportation. And people cannot utilize a food pantry if they don't have a car. You cannot get that much food home on the bus. So they really overlap those issues.
Mhm.
Yeah, and for those who are outside the Omaha area or under-resourced places as well, 311.org is a great list of resources, not just food related, but lots of additional services. So that's a good place to steer people. If you don't have, for example, a social worker or somebody else, that 311.org will be a great list of a lot of local resources for patients.
That's fantastic. Thank you. One last thing that was asked, what are some ways that you might navigate the stigma surrounding obesity care? Our patients come in all shapes and sizes. How may this impact approach to your care?
My life was really changed doing an e-module on obesity bias. And I realized, one of the first things you see before you even meet a patient in their chart is their BMI. So really trying to notice that subconscious bias right away and instead, turn it around to say, I assume this person has been not treated the best within the healthcare system because we know statistically that happens. And I feel really honored that they're choosing to come to see me anyway. And yeah, just that. And also, like I teach the med students, and I also think about at what point did you have control over what you were eating? Was it when you were in the womb? No. And that affects our weight as adults. Was it when you were 0 to 6 months, 6 months to 2 years? Was it when you were a teenager and all the marketing said to eat unhealthy foods? No. And usually med students are like, I don't know, I might be getting close, but they don't have necessarily the money to get all the healthy food they want. None of us maybe have the time to cook all the healthy food we want. So there's so many things that go into it, like really understanding that it's not the patient's fault and that the body they have, we want them to accept the body they have, and we need to accept the body they come to us in.
Mm-hmm. Yeah, and I really try to focus on, again, nutrition. So it's not a number, it's not the perfect scale. It's, having a healthy body and taking care of our body as best we can. We all know that there are skinny people who are unhealthy and there are overweight individuals who are healthier. And so we want to focus on health. And so I try to reframe that I think that there's so much bombardment of messages of the skinny is the ideal, but we need to reframe that healthy is the ideal, and healthy can look different in different shapes and sizes. So I try to really kind of reframe that to really focus on health.
Great. Thank you. Any other questions from the group we have on today? Well, if we're waiting for that, I just wanted to share this last couple slides. If today sparked any questions or interest, just want you to know that LifeBridge is a resource for you. Our coaches are happy to talk through things. A lot of times it's talking through examples of what conversations you might have with patients. And following the passage of legislation in 2023, our program is the only one to be state protected under statute. And so people participating in our program are protected against discovery of any conversations that are had there. And then finally, I just want to thank our sustainability partners so that this program remains at no cost to them. But if there is no other questions, Dr. Evans, Dr. Hartman, thank you both for joining. This has been a long time topic coming. And like we said, this could probably be broken up into 5 more topics about nutrition, but we appreciate you guys answering all of our questions today.
Thank you so much.
Thanks for having us.
Thanks for having us.
Yeah.
Have a great morning.
You
Bye.
too.
Thank you.